The broadcast is now starting. All attendees are in listen-only mode.
Hi, and welcome to the UABMD Helpful Webinar, Sleep, Take It to Heart, hosted by Dr. Susan Hardy of the UAB Sleep and Wake Disorders Center. My name is Katie. I'm with UAB Medicine, and I just want to take a moment and make sure that everyone can hear me. So if you look at the toolbar on your screen, you should see a small button that has a little hand on it. And if I could just get you guys to click on that button to let me know that you're able to hear. Okay. All right, it looks like almost everyone can hear me. For those who can't, we'll be sending chats out and make sure that they can get hooked up via telephone. I just want to let you know, as far as questions are concerned, Dr. Harding will be doing a Q&A session the last 15 minutes of the webinar. But we do encourage you to go ahead and chat those questions in through your toolbox. So you should be able to see a little chat section or a question section, and you can type those in. I'll be taking those into Dr. Harding, and she'll address them all at the end. So just remember, she won't be answering them during the presentation. She'll answer them at the end. But we want you to go ahead and send them in so we can get them on the list and get to as many of them as possible. So with that said, I'm going to turn things over to Dr. Harding. Thank you for attending.
Very much. It's a pleasure to be here. We're going to talk a little bit today about sleep and how sleep can influence health in general. So when we talk about health, some things we can't change, like our genes. However, there are 3 things we can actually do to improve our health. And one is adequate nutrition and good nutrition, thinking about low fat and not eating too many calories. Exercise is very important for both sleep and health, and I think that's one of the best ways you can do to prevent many health problems. And then third is sleep, and unfortunately a lot of Americans are not getting enough sleep, and sleep deprivation really can impact health as well. So the goals of our time together today include a little bit of understanding about what normal sleep is and how a very common sleep disorder called sleep apnea can actually affect your health as well as your heart. And then discuss some of the health risks of not getting enough sleep, because many Americans really don't get enough sleep. And then review some symptoms of obstructive sleep apnea, which is a common disease that affects about 4% of guys and 2% of premenopausal women, and then discuss treatment options for obstructive sleep apnea. And then importantly, that if you treat obstructive sleep apnea, you actually can improve cardiovascular health, including decrease the probability of actually dying from a heart attack or a stroke. So with that, let's start with discussion of the importance of sleep. Dr. Alan Brechenschaufen in 1970 noted that if sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made, since we spend about 1/3 of our life sleeping. And it is vital. Without sleep, in animal models, they die within a few weeks. For us, sleep is very important for learning and memory, especially in school-age children. Our mental function, our ability to solve problems, as well as our physical performance is impacted by sleep. For instance, if you're planning to have elective surgery, you may want to make sure your surgeon had adequate sleep the night before your operation. Mental health is very important for mental health as well as physical health, as we'll discuss. But what is normal sleep? Normal sleep should be restful and restorative. You should wake up feeling refreshed. And during sleep, we have a relative disconnect from the environment, so that you may not hear a tornado alarm going off. So it's important to have a secondary alarm system to help you if a storm comes in. The normal sleep requirement is determined by genetics or your genes, but most of us need about 7.5 to 8 hours of sleep a night, or we don't get enough sleep. And actually children, especially in the early teenage years, need closer to 9 hours of sleep. And that should be a good benchmark to think about. Sleep has its own architecture, just like a house, and there's different sleep stages which have different functions and bindings. So sleep stages also change throughout the sleep time. When we talk about sleep stages, we define them by brain activity that we can monitor by brain waves or EEG, eye movements, and also muscle tone. When we think about the sleep stages, there's two general subcategories: non-REM or non-rapid eye movement sleep, which is further divided into stage N1, which is more like church sleep, sort of a transitional stage, followed by stage 2, which is where we spend most of the night, and then stage N3, which is when growth hormone is secreted, and is important for muscles and refreshing findings. And then we have rapid eye movement sleep, where actually our eyes move very quickly, and this is dream sleep. This is when we actually dream. So when we talk about sleep stages, we're either awake, and sometimes we can wake up or arouse multiple times during the night and really don't remember it. Then we have non-REM sleep. As I mentioned, stage N1 is sort of very light sleep, church sleep. Your muscles relax, your heart rate slows, and it takes up about 5% of your total sleep time. And then N2 sleep, where we spend most of our time, about 50% of total sleep time. And during this time, our breathing becomes very regular, our heart rate and blood pressure actually decrease, and our body temperature also decreases. Another stage of non-REM sleep is N3 sleep, which occurs about 20% of the sleep time in young adults, and it usually occurs in the first third of the sleep time. And different disease problems during sleep come up during different times, like sleepwalking more commonly comes up out of N3 sleep, and so you're going to see it in the first third of the sleep time. So if they go to bed at 9 o'clock, it's more likely to occur in the first third or before midnight. We also call it slow wave sleep, deep sleep, or delta sleep. Our muscles further relax, and unfortunately, we have less N3 sleep as we age. So now that I'm in the upper age category, I get minimal N3 sleep, although women were more prone to have more than the guys as we get older. Furthermore, heart rate and blood pressure further decrease, and there's a very regular breathing pattern. N3 sleep is very important because it's when tissue repair and regeneration takes place, and it's also when growth hormone is secreted. Now, REM sleep is very important as well and makes up about a quarter of sleep time, and it occurs at its own rhythm. About every 90-minute intervals it comes in. And it's more common during the later third of the night. This is when we dream more commonly, very vivid dreams, and we actually become paralyzed, so we don't act out our dreams. In fact, there is a sleep disorder called REM sleep behavior disorder where patients actually act out their dreams because they don't have this muscle paralysis. Also, we become cold-blooded animals during dream sleep, so if you camp outside and it's very cold during dream sleep, your body temperature will get closer to the ambient temperature. It's also when penile erection occurs in guys, and in women we get clitoral blood flow increased as well. Memories are stored during this sleep time. It's very important for learning, and so if it occurs in the later third of the night, you don't want to decrease the amount of sleep you get by waking up too early. You're going to miss out on your dream sleep. Now, REM sleep or dream sleep is a very unstable time for the heart. We have intermittent surges of what we call sympathetic tone, where the heart rate will just rocket and go up. There's also fluctuations in blood pressure that can occur, and breathing becomes erratic as well. So it can be a very difficult time as well, and heart rhythms can occur also during this stage. So when we think about sleep throughout the entire night, it has sleep architecture. And we also talk a little bit about sleep cycles. And a sleep cycle is defined as a time a person initially goes to sleep through the first dream sleep. And it occurs, within around 90 minutes. So every 90 minutes or so, another REM comes on, which is a sleep cycle. So your first sleep cycle is from sleep onset to the finish of the first REM, and then it occurs again and again with more REM in the later third of the night and more N3 or slow wave sleep in the first third of the night. And this is just a picture of a normal sleep architecture of a young adult, showing the different sleep stages. And you can see that there's more REM sleep or dream sleep in the later third of the night. And we have less deep sleep noted during the later third of the night. So the first question I have to everyone today is, did you get enough sleep last night? And I want you to carefully assess this because most of us are not. Unfortunately, we need to make sleep more of a priority in our society because not enough sleep is associated with a lot of problems. Sleeping less than 6 hours a night is associated with a 48% increased risk of developing or dying from coronary artery disease. There's also a 15% increased risk of having or dying from a stroke. Inadequate sleep time is also associated with high blood pressure. Also, if you do x-rays or CT scans of coronary arteries, you can actually have an increased risk of coronary artery calcification, an increased risk of coronary artery disease. When we talk about our autonomic nervous system, our sympathetic nervous system can elevate blood pressure, and there's evidence of sympathetic nervous system activation in people who do not get enough sleep. Also, cardiac disease is associated with many markers of inflammation, including elevation of C-reactive protein, and this is increased in people who have inadequate sleep. And not getting enough sleep is actually associated with increased mortality. Furthermore, inadequate sleep time is associated with insulin resistance and diabetes, in fact, increasing your risk by about 28%. It increases stress hormones. Also, inadequate sleep is associated with weight gain. For instance, in the Nurses' Health Study, a study of more than 78,000 women nurses, those who had less than 6 hours of sleep a night gained quite a bit of weight during the follow-up period. There's also increased appetite, especially for high-fat, high-carbohydrate foods. And a recent study showed that people who had less than 6 hours of sleep actually ate approximately 300 calories more a day, and if you add up over time, really adds up a lot. Furthermore, inadequate sleep is associated with decreased leptin. Now, leptin is the hormone that's actually secreted to make you feel full, so this is really a problem. And so inadequate sleep time is associated with a lot of health problems. So with that, the first thing you need to do is ask, are you getting enough sleep? The other thing, you want to optimize your sleep. So make sure that you make 8 hours for sleep. Make it a priority. Don't make it a secondary priority. Oh, I've got 2 jobs, I've got kids, I've got to get ready for school. You need to make it a priority. You want to make a regular schedule. Maintain a consistent time to go to bed and wake up. The key issue is this is every day, even on the weekends. Otherwise, on Monday morning, you sleep in late on the weekends, you're going to have trouble getting up. Avoid bright light because light tells our brain it's time to wake up, especially blue light, computers from iPads, TVs, blue lights everywhere. It causes alertness. Avoid things that disrupt sleep like caffeine, alcohol, large meals, smoking before bedtime. Make sure your sleep environment's good. Make it quiet, dark, no pets in there waking you up, no TV. Think about you. Think about relaxation time for you. You can even do relaxation therapy things like deep breathing exercises. And then if you have a sleep problem, discuss it with your physician. So let's talk a little bit about what happens to blood pressure during sleep. Blood pressure is a top number and a lower number, the top number being the systolic pressure, which is the maximum pressure in the arteries. It develops when the heart contracts. Diastolic pressure is a lower number. It's a pressure in the arteries when the heart is relaxing. Normally during sleep, we actually have a decrease in blood pressure. We call this the nocturnal dipping. And it's really important because during sleep there is a decrease in sympathetic nervous system tone and our blood pressure goes down. Lack of this nocturnal dipping is actually a risk factor for having cardiovascular disease as strong as other risk factors, including diabetes or hypertension. And unfortunately, with a sleep disorder called obstructive sleep apnea, you have loss of this nocturnal dipping of the blood pressure. We also see it in other diseases, including diabetes, chronic kidney disease, and older people are less likely to have this nocturnal dip. And this is what it looks like. Normally, over the 24-hour period, you have a relative decrease in blood pressure during sleep time, assuming the person is sleeping during the nighttime hours. And then if you don't have this non-dipping, your blood pressure stays elevated throughout the 24-hour period, and so that you have more of a blood pressure load throughout that time, which increases risk for cardiovascular disease. The other thing is that cardiac events do occur during sleep. For instance, 20% of heart attacks occur during sleep, 20% of atrial fibrillation episodes, which is irregular heartbeat, occur during sleep, and 15% of sudden death episodes also occur during sleep. So it's important to think about this, that sleep is associated with cardiovascular events. So one of the most common sleep disorders that I see at our center is obstructive sleep apnea. And one reason I really love doing sleep is because I really can get my patients better. And if I can prevent a heart attack or a stroke, I'm a happy lady. So what is obstructive sleep apnea? Well, first, it's a pause that does not refresh you. And apnea comes from two Latin words, a meaning without, and pnea meaning air without air. So it's repetitive episodes in which the upper airway, which is between the nose and the voice box, collapse and stops airflow where the person is still trying to breathe. So you see their chest going up and down and they're not moving any air. Then it's followed by a loud snort where they actually arouse or wake up and they start breathing again. Now what's important is that with these apnea events, there's no air movement, so the amount of oxygen goes down in the body. There's also an increase in blood pressure and heart rate at the end of these apneic events. And this can occur multiple times throughout the night, hundreds of times throughout the night. So what happens when we go to sleep is our upper airway muscle tone goes down. So there's less volume in the back of the throat. There's snoring and airway blockage, so it actually blocks off the airway. You can't get any air. And this is just an example from a diagram from a sleep study showing the EKG airflow, whether the person is trying to breathe with thoracic and effort and abdominal effort, and then the SaO2 is the oxygen saturation. And what happens is that the airway obstructs, so there's no air, and the person still continues to breathe, and there's also a decrease in oxygen level. Then the person usually arouses, opens up their airway, and the cycle begins again. Now, another thing that happens is a hypopnea, which means less air. And here the physiology is the same. That is, there's decreased airflow as well as continued respiratory effort followed by an arousal and an oxygen desaturation. And so when you look at it, you still have that increase in heart rate and blood pressure with a hypopnea. So we treat apnea and hypopnea as the same. So what happens during an OSA event or obstructive sleep apnea event? There's low oxygen levels in your blood. We define that as hypoxemia. There's wide swings in blood pressure and heart rate. You have increased breathing effort, and so there's a lot of pressure changes in your chest, which actually can decrease the amount of output your heart is able to do. And then you wake up multiple times with these arousals, and then after the oxygen level goes down, it goes up. And one of the theories of heart disease and obstructive sleep apnea, how they're linked, is that there's free radicals released with this reoxygenation, which damages blood vessel walls itself. So how common is it? It's as common as asthma. About 4% of middle-aged guys and 2% of middle-aged women have obstructive sleep apnea. But women beware, we catch up with the guys when we hit menopause, and that's when we get it after menopause. The other thing is that patients with cardiovascular disease have an increased risk of having obstructive sleep apnea. So what that means is that if you have hypertension, your risk is increased. For instance, 80% of people with difficult to control high blood pressure have obstructive sleep apnea. If we were to look at consecutive stroke patients, 60% of them have obstructive sleep apnea. 50% of patients with congestive heart failure have sleep apnea, and 30% of patients with coronary artery disease have sleep apnea. So the key here is that if obstructive sleep apnea is identified and treated, it could help prevent future events, even in people who have heart disease already. So what are the risk factors for having obstructive sleep apnea? One of them is obesity, which, as you know, is an epidemic in Alabama. Guys, until the women hit menopause. Facial structure may predispose you, like your jaw is not as prominent. Nasal congestion, enlarged tonsils. Certain medications, such as benzodiazepines and opioids, decrease muscle tone, and that increases the risk for having sleep apnea, as well as alcohol. Low thyroid levels, as well as a family history of obstructive sleep apnea, can also predispose to having obstructive sleep apnea. So what are the symptoms? Well, a lot of us had bed partners, and we may notice some things. So when we talk about getting a sleep history from someone, we want to include their bed partners because they could tell you information you don't know about since you're trying to sleep. They include loud snoring or snorting associated with arousals. And a lot of times arousals are sort of like jerks, these little jerks people make. You may have witnessed apneic events where you're still trying to breathe and not moving any air. People may notice irregular breathing patterns, mouth breathing, because usually during sleep you breathe through your nose, and a common complaint is a dry mouth. So the other things people can complain of is frequent arousals, feeling unrefreshed, restless sleep, night sweats, insomnia, decreased libido, problems with thinking impairment, personality changes, morning headache, wake up with a dry mouth, excessive daytime sleepiness, you may feel sleepier than you did before, and even nighttime urination. And actually the reason behind nighttime urination with obstructive sleep apnea, the reason was actually found at UAB. You actually secrete a hormone from the heart that causes people to urinate, and treatment may improve that. However, being a woman myself, I understand that we do not present like the guys. We're less likely to have those witnessed apneic events. We're more prone to have more daytime sleepiness and be treated for depression. So our physicians may not consider the diagnosis of obstructive sleep apnea. So that's important to remember when you discuss it with your primary care. So what are the risk factors for sleep apnea? If you do a physical exam, what a physician does when you get evaluated, you look for abnormalities in the upper airway especially. This is an example of a deviated septum in the nose which blocks off the airway. Another thing people don't think about is that if you have had a history of braces or orthodontic work as a kid, may be a risk factor for sleep apnea because your jaw may not be as developed, so there wasn't enough room for your teeth. And that's another risk factor, a type 2 overbite. This is an example of a person that actually had very large tonsils that were actually obstructing the airway. We also look at neck size. Neck size is a predictor of whether people would have sleep apnea or not, and it's 17 inches or more in guys and 16 inches or more in women. So if you come to the sleep clinic, you may be surprised that we're actually doing this measurement. So we've talked a little bit about how people present with obstructive sleep apnea and what we may find when we examine our patients. But what happens to people with obstructive sleep apnea? What are the consequences? One of the most common problems is very sleepy during the day. They may notice that they have trouble driving because of sleepiness. They feel more tired. They have trouble staying awake. They may notice some problems with thinking and ability to do complex problems, depression. People with untreated sleep apnea are more likely to have motor vehicle accidents because they have trouble staying awake. They notice a decreased quality of life, morning headache, weight gain, and insulin resistance is also seen, and then disruption of the bed partner's sleep, also cardiovascular events. Drowsy driving is a major problem. In fact, you always think about it, especially in car accidents, and don't drive if you're drowsy because you could injure yourself. There's many cardiovascular consequences of untreated sleep apnea. High blood pressure, heart attack, heart rhythm problems, cerebrovascular accidents or stroke, sudden death, and pulmonary hypertension. So it's important if you have sleep apnea to get it treated, because more and more data is coming out showing that treatment of sleep apnea lowers cardiovascular risk and even death. Obstructive sleep apnea is associated with myocardial infarction. Death is increased in those who have an apnea index of more than 20 events an hour. And cardiac patients with high rates of obstructive sleep apnea have far higher rates of MI. So it's a very important factor in myocardial infarction. So what usually happens is that if you have symptoms of sleep apnea, you may want to talk to your primary care physician about it, and they may refer you for further workup. The reason to find out if you have it is to establish a diagnosis, determine how bad it is, provide a baseline for follow-up care, and then when we treat it, make sure that we adequately treated your obstructive sleep apnea. So this is, if you come to UAB, you come to the UAB Sleep-Wake Disorder Center. This is at UAB Highlands campus. And as you come out the elevator, this is what you'll see. I am fortunate to practice with some outstanding physicians. All of us are board certified in sleep medicine. Sleep physicians come from a wide variety of medical specialties. We have people in pulmonary critical care. Dr. Calhoun is a hypertension expert in the Division of Cardiovascular Disease. Dr. Hawkins is a pulmonologist. Drs. DeWolf, Amara, and Bolwald are experts in neurology. And so we all work together to provide good care for our patients. When you come for a sleep evaluation, you will see one of us. And then if we feel that you need a sleep study, it can be scheduled the same day for a later date. You have your sleep study at the same place you come for your clinic visit, and we show you that during your clinic visit. The sleep study usually starts, so you usually come at about 8 at night, and you prepare for sleep, and we monitor different things during sleep. The next morning, the physician actually goes through the data and reports to you the findings of your sleep study, so a treatment plan can be started. This is an example of our one of our exam rooms. When we do a sleep study, we sort of monitor a lot of different things that happen during sleep. We measure what stage of sleep you're in with brain waves, muscle tone, which is the chin EMG, and eye movements, the EOG. These are a lot of stickers all over your head. We also measure airflow. We measure whether you're trying to breathe with belts around your chest and abdomen. We measure whether you're snoring with the microphone. And then we monitor oxygen saturation with the pulse oximeter on your finger. We monitor what position you're in, since obstructive sleep apnea is commonly more severe when you're on your back. We also measure EKG because heart rhythm problems can occur during apneic events. And then we look for other things like leg movements. There's more than 90 sleep disorders, so we can document a lot of different things during sleep. And depending on your sleep problem, we may do different types of monitoring. So a split night study is where we actually start off the night looking to see what's going on. And then if we see something like obstructive sleep apnea, we'll start treatment. And the most common treatment for obstructive sleep apnea is nasal CPAP, or continuous positive airway pressure. So hopefully we can do everything in one night. We're also having the capability of doing a portable sleep study where we monitor limited things, including respiratory parameters and oxygen saturation, so it can be done at home. And we usually reserve this for people with a clear history of obstructive sleep apnea and not a lot of other health problems. And this is an example of one of our technologists, Amanda, actually showing a CPAP device to one of our patients in one of our sleep study rooms. We try to make it look halfway like home. And this is actually a page from an actual sleep study. And the top third of the recording is we're monitoring sleep stages with all the brain waves. Then you can see the EKG. And then in the lower third, you can see the airflow followed by the respiratory effort. And there's a few things I want you to notice on this. The first thing is, I think you can see in the lower third that there is a very long apnea period. Actually, this one is quite long. And at the end of the apnea period, where there's no air, you can see there's still respiratory effort on the bottom two channels. You can see there's a big jerkish type motion where everything is sort of black, and that's the arousal from the apnea. The other thing I noticed that's interesting on this recording is that in the middle of it, the middle of the page, you can sort of see a funny heart rhythm sort of looks different. And that actually is a major cardiac rhythm that occurred during apnea. And this is something we can see very, very often. So when we look at the sleep study, we actually count. We count how many full apneas there are, how many apnea and hypopneas there are, how many hypopneas there are, and we sort of have this Campbell soup recipe of apnea-hypopnea index, which is where we count up how many apneas and hypopneas a person has per hour. And normal is less than 5 events an hour, mild is 5 to 14 events an hour, moderate is 15 to 30, and severe is 30 or more an hour. So it gives us an idea about how severe the problem is. Now, once we make a diagnosis of obstructive sleep apnea, how do we treat it? Well, there's a lot of different treatments, and I want to go through some of those. First of all, if someone is obese, it's important to lose weight. And this can be done by diet and behavior modification. Dr. Ard at the Eat Right program does a very good job of this. We also are, UAB is a center of excellence for bariatric surgery. In fact, all of the bariatric patients actually get evaluated for obstructive sleep apnea before having surgery, so that if they do have obstructive sleep apnea, it gets treated to help post-op complications. So obesity is a very important risk factor for having obstructive sleep apnea, so it can help. And in bariatric surgery patients with obstructive sleep apnea before surgery, when they get to their baseline weight or their target weight, about 85% of them who had sleep apnea before surgery are actually able to get off CPAP, and it helps their, they don't need to wear CPAP anymore. Another thing you can sometimes do is sleep apnea may be more severe on people's back, as you can use positional therapy to keep people off their back, and that helps especially in mild cases, especially if they only have apnea on their back. Other things is to avoid alcohol and airway irritants such as smoking, which make the upper airway smaller, and then avoid medications that can worsen sleep apnea, including benzodiazepines and opiates. Now, the standard of care is actually something called nasal CPAP. Basically, what it is we mechanically stent the upper airway because it collapses. We blow air in, usually through the nose, continuously, and it opens up the airway just like blowing up a balloon. And that works in more than 95% of people. There's different ways to give this air. Nasal CPAP stands for continuous positive airway pressure. It's sort of like a constant pressure. You can also use bilevel, which is a higher pressure during inspiration and expiration, and sometimes that's called BiPAP. And then there's a sophisticated machine called auto CPAP that monitors what pressure you need to open up the airway and changes pressure depending on what the machine finds. So it changes pressure throughout the night, and usually this results in a lower pressure during the entire sleep time versus CPAP. Another interesting treatment is something called an oral appliance, which is something you put over your teeth, and it moves the lower jaw forward, so it increases the space behind the throat and decreases apnea. Then you can do surgery of the upper airway, either soft tissue surgery or jaw surgery, to increase the airway size. The first treatment for obstructive sleep apnea was a tracheostomy, where they actually made a hole in the trachea or the windpipe to bypass the upper airway. And fortunately, we don't have to do that very commonly anymore since we have better treatment. So let's talk about treatment some more. Nasal CPAP is the treatment of choice. It works in more than 95% of patients. It's not as costly as surgery. However, in order for it to work, you have to wear it. And it's a difficult treatment. It's hard to get used to. You got to put it on. There's all kinds of hassles with it. But a key mask fitting is key. It has to be comfortable. We use heat humidification to help. We work with people to try to get them on CPAP. And when you look at CPAP versus other treatments, including surgery, like something called the UP3, there's improved long-term survival. And you can retitrate it if the patient's clinical condition changes, like if they lose weight or gain weight, we can change the pressure. And this is just an example of what a CPAP machine looks like. You sort of plug it in the wall, and it's like an old-fashioned hair dryer. It blows air in. You have an interface or a tube, and then it interfaces to the nose, and it opens up the airway, and you go to sleep with it. There's different mask types, depending on which one is most comfortable for the person. This is an example of an upper airway with CPAP. And with the red arrow, you can see that with higher levels of CPAP pressure, that is in centimeters of water, it increases the airway space, and it's just showing CPAP in action. Now, all appliances, as I mentioned, is something you place over your upper and lower teeth, and it actually works quite well in people with mild apnea, especially those who are not obese. And this is an example of two such appliances, and you can slowly adjust the silencer so that the lower jaw moves forward over time. Now, a UP3 is usually done by an otolaryngologist, and what's important to note is that it only gets rid of one of the areas of obstruction, and so only about 14% of patients have an apnea-hypopnea index of less than 5, which is our treatment goal postoperatively, and there's not a lot of good predictors for response. Now, there is another type of surgery that we call region-specific surgery, where they actually do a detailed examination of your airway, which may include CT scans, and sort of look to see where areas of problem may be. And this includes actually surgery where they move the upper and lower jaw or bone forward, which increases the space in the back of the throat. And this is what it looks like from a schematic diagram, and even though it looks like it is a major thing, it isn't, and the outcomes of this actually are quite good and better than the soft tissue surgery or UP3. And Dr. Peter Wade at UAB has a long record of performing such surgeries with good outcomes. So it is another potential treatment option. So why worry about treatment of CPAP or sleep apnea? And this is what gets me so excited about practicing sleep medicine. Even after a half a night of CPAP, patients feel better. They feel more refreshed. But more importantly, there's a lot of studies coming out looking at how CPAP can affect health. It improves blood pressure. It also decreases cardiac rhythms. For instance, people that have a history of atrial fibrillation, if they have obstructive sleep apnea and are compliant or adherent to CPAP treatment, they're more likely not to go back into atrial fibrillation after they're cardioverted. It also improves heart function. There are some patients that have gone from being on the transplant list for a heart transplant to having normal cardiac function with treatment of their sleep apnea. And it reduces mortality. I guess a really good study that just came out actually in January was from Spain, and it showed that over 6 years in women with obstructive sleep apnea, if they were compliant with their CPAP use for treatment of sleep apnea, they had a marked reduction in mortality. And this was the first study that really looked at outcomes in women, because most of the studies in the past were done in men. But multiple studies show that CPAP can decrease mortality as well as cardiovascular events. So it's very important if you have sleep apnea to get it treated. So I think it's almost time for questions. I just want you to remember that sleep can impact the heart. Remember that you need adequate sleep time for your health, and getting less than 7.5 hours can really impact your health in general, including your cardiovascular risk. Obstructive sleep apnea can affect cardiovascular health. If you have symptoms of sleep apnea, it's important to get evaluated in treatment, since treatment of obstructive sleep apnea may help lower blood pressure and possibly prevent a heart attack or a stroke. And this is just an example of some of our team people at the Sleep Center, including Dr. David Calhoun in the upper part, and then a 30-second page or epic from a sleep study showing an apnea with an arousal. And then again, our Sleep Center is at UAB Highlands, and It's really a nice place. There's free parking very close. So that's where we do everything related to sleep right now. So with that, I'm open for some questions. We've got some time left for that. So I have a question from Timothy. Are there any viable alternatives for sleep apnea sufferers besides BiPAP and CPAP? Is there some mouth appliance that could work? And the answer for that is yes. I showed briefly the oral appliance, and that is very good. It's especially works well with people with good dental health and those with a small jaw that aren't as obese. There are surgical options, as I talked about. What's coming up in the future potentially are two treatments. One treatment is actually pacing the upper airway muscles during inspiration to open up the airway, and that's experimental right now, sort of like a pacemaker you turn on and off when you go to sleep. That's probably a few years away. And then there's a way to develop upper airway opening using little stickers over your nose to allow more air to stay in place, and that works in some patients, and that's what's in the future as well. Barbara has a question. I had a sleep study very early on when these were beginning to be offered and was diagnosed with OSA. Is there a reason to get another sleep study done? Well, if you had a sleep study years ago, unless you had major changes in your health, including weight loss, you probably still do have sleep apnea. So, you know, we decide whether another sleep study needs to be done if something's changed. You probably still need treatment unless something's major change. If you lost a lot of weight, potentially we could see if you still have sleep apnea. If you've had surgery in the past, such as a UP3 or other upper airway surgeries, we could see if it impacted your sleep apnea. Most of the time, we don't necessarily have to repeat a sleep study on a regular basis. Some people can have sleep apnea diagnosed as children, and in children, tonsillectomy actually is very helpful. It's not as helpful in adults. So it's important to ask your doctor about whether you need another sleep study. Most of the times you don't, and sometimes we can adjust CPAP or whatever treatment you have based on what your symptoms are, and we can actually do other things to see how you're doing. Susan asked, if you have heart valve problems, would dream sleep and instability of heart potentially be a problem? Well, that's an interesting question. There's a lot of different heart valve problems. One of them is mitral valve prolapse, and people with mitral valve prolapse occasionally have sort of a dysregulation of the autonomic nervous system. And with that, you can have more varied blood pressure changes and heart rate changes during dream sleep. So, you know, potentially you can have more rhythm issues as well during dream sleep. So it sort of depends what type of heart valve problems you have and whether it's near the conduction system of your heart as well. RN, what is C-reactive protein? Actually, C-reactive protein is a marker of general inflammation. We see it whenever you get a cold, it goes up. But in people who don't have acute problems, actually it's a good marker of potential risk of cardiovascular disease. And it sort of just is a general marker of increased inflammation. It can be caused by a lot of different things as well. And what about the effects of sleep on your Ghrelin? Well, that's the other side of the story of the leptin. And inadequate sleep is actually alters your Ghrelin as well. And one of the things that is also interesting is that just like there's insulin resistance, there's leptin resistance, and that may be another effect of inadequate sleep time is actually changing your Ghrelin so that you're actually more prone to get problems with leptin resistance. Let's see, another question is, what do you mean by titration? Well, A CPAP titration is when we start off with a very low pressure, like 5 centimeters of water, and with that, we monitor what's going on live during the sleep study, and we titrate the pressure until the apnea is gone, and then it usually takes another 1 or 2 centimeters of water to titrate up to get rid of the snoring, and that's what a CPAP titration is. How do you know if you're a dipper or a non-dipper? Well, you can do that with ambulatory blood pressure measurements. There are ways to do that. In research, we do it all the time. Sometimes these intermittent blood pressures actually wake people up from sleep. You can buy ambulatory blood pressure gauges through medical device companies or through the internet. And that's really the only way you know if you're a dipper or not, is actually measuring it through the night. From Susan, when I wake up, I never feel good. I have connective tissue disease, bronchiectasis, a portion of bronchiectasis. Do you have a lower level of oxygen transfer during sleep? That's a very good question, Susan. And one of the things that is very important is that the amount of air movement we have during sleep goes down. What happens during sleep is that our muscle tone goes down, and so as you know, the diaphragm force is not as strong, and our muscles in our chest wall may not contract as strongly, so our lung volumes are down, so we don't take as deep breaths. Also, our ability to clear secretions during sleep goes down, and that's one reason why coughing and sputum production go up when you first get up in the morning, because things sort of slow down during sleep. It is possible during sleep that your oxygen level may be markedly lower during sleep than during wakefulness. In fact, even normal people have a decrease in oxygen a little bit during sleep, but in people with lung disease like yourself, it may be even more so. What I would recommend doing is talking to your pulmonologist about possibly getting an overnight pulse oximeter, where it's a little red light you put on your finger. We measure it all the time in clinic, but it actually can measure over time, and it can be downloaded, and your doctor can see if you have significant oxygen going down during sleep, and I would recommend that be done. People with cystic fibrosis, COPD, asthma, all these people have risk of significant oxygen going down, especially during dream sleep when our muscle tone goes even lower. If someone snores or makes grunts, does this mean they have sleep apnea? Well, it is one of the risk findings of having sleep apnea, and especially snorts can be associated with sleep apnea, so you may want to be discuss it with your physician. If I have OSA and I'm waking up hundreds of times every night but not remembering, is that why I'm so tired in the morning? Yes, that's true. These arousals are usually 3 seconds to just 10 seconds, and so basically you may wake up and not remember it, and that's why it's important to ask a bed partner if they're noticing anything during sleep. Some people have actually video recorded themselves with their iPhones during sleep as well, but if you have a problem like that, it may be good to get seen. Now, Nikki asked, do you have to have a referral for an appointment? The answer to that is generally no. You're welcome to make an appointment at our sleep center anytime. However, certain insurances require a referral for an appointment. So before doing that, you may want to check with your insurance coverage to make sure that you do not need a referral. But yes, you can call and make an appointment without a referral if your insurance allows it. Lynn asks, I've heard people with fibromyalgia can be helped with this. Is that true? That's a good question, Lynn. People with fibromyalgia have poor sleep, and there's a lot of reasons for that. First of all, chronic pain can impair sleep. Also, people with fibromyalgia actually have an increased risk of having sleep apnea, and they actually have an increased risk of having other sleep problems, including restless legs and something called periodic limb movements with your leg jerks. And so one of the key issues for people with fibromyalgia is to really look for sleep problems that we can treat, and that may actually help pain. So you may want to be evaluated for sleep problems, because improving sleep may improve pain, and CPAP, at least in a small study, showed improved pain scores in people with fibromyalgia who had even mild sleep apnea. Is there an age range for sleep clinic? Yes, there is actually. We're fortunate to be at UAB to have 2 sleep centers. We actually have a sleep center at Children's Hospital that treats children with sleep disorders, and that is at Children's Hospital, and you can check the UAB Medicine website for their phone number. So if you have a child with a sleep problem, they would be the place to go for that. Lorraine, is there such a thing as too much sleep? Well, that's interesting. I talked about inadequate sleep time being associated with health problems, but so is too much sleep. And too much sleep for some people, maybe 10 hours. What's interesting is that it is genetically determined, and some people need 10 hours to actually feel good, and those who do need 10 hours of sleep also are at increased risk for health problems as well. We call it the U-shaped curve. Too much sleep or too little sleep is associated with health problems. Charlene asked, what is a treatment for keeping on your CPAP when you don't remember taking it off during the night? Well, that's a common problem, and we see that more commonly as people start using CPAP, and there are some tricks you can do. One of them is every time you take it off is if you do wake up, put it back on. The other thing is that you can put socks on your hands so you can't take your CPAP. You're not as agile during sleep, and that may do it as well. Most people, after they get used to it after a while, don't take it off. The other question to ask is, do you have a pressure that's too high so it bothers you? So you may want to discuss that with your physician. Virginia asked, is severe cramping in the legs during sleep a symptom of a sleep disorder? Well, leg cramps really hurt during sleep and can wake you up during sleep. And that in itself is not a sign of another sleep disorder other than having leg cramps during sleep. And it's very difficult to treat leg cramps. Sometimes stretching helps before bed, making sure you have adequate nutrition on board, such as adequate potassium, and eating right, and not overly exercising, but doing some mild exercises may help. Cindy asked, is hypothyroidism a result or cause of OSA? And actually, that's an interesting question. People that have hypothyroidism actually have an increased risk of having obstructive sleep apnea. And this may be because in the setting of not enough thyroid hormone, you have changes in your upper airway that include some thickening of the airway, which makes you more predisposed to having sleep apnea. And treatment with thyroid hormone may actually improve obstructive sleep apnea. So it's probably what we call a bidirectional relationship. It's important that if you have hypothyroidism to get it followed up on a regular basis, but it is a risk factor for having obstructive sleep apnea. And then there's another question, how do those people who require less than 7.5 hours sleep fever out in terms of morbidity and mortality? And that's a very important question, and that's something I don't think that research has fully delineated. There are people who are, quote, short sleepers. For instance, former President Kennedy was a short sleeper and only needed 4 hours of sleep a night to feel great. That's different than someone that is sleep restricting themselves. And most of the research that's been done lately was done on those who sleep restrict themselves because of demanding lives, not making sleep a priority. So we're not totally sure about differentiating those that require less than 7.5 hours and still feel great and those who sleep restrict themselves. I have a patient, there's a patient here that has a BiPAP that has a temperature control to warm the water, but my throat still gets dry. Any suggestions? Yes, what you have is called a heated humidifier, and that really helps warm up the air. As you know, one of the functions of our nose is to make the air warm and moist, and that helps us breathe better. And when you have BiPAP or CPAP, actually more air is going down that nose and it dries it out. So one thing to think about is whether you're opening your mouth during the BiPAP. That is often a problem. And if that's the case, you can either change out masks or try a chin strap. The other thing you may want to ask is whether the pressure is too high or too low with your BiPAP pressure right now. And I would probably recommend just seeing if your sleep apnea is adequately treated and make sure you're not having any mask-related issues. And then try changing the humidifier temperature as well and see if that helps. Another thing that may help is actually making sure that, especially right now during allergy season with all the pollen out there, is make sure that you're not having nasal congestion. You can potentially use inhaled steroids to open up your nasal airway. Some people use nasal saline washes to open up the nasal airway, so you're less likely to open your mouth. Now, can you use a CPAP machine without having a sleep study performed? Well, potentially, yes. You're not sure exactly what pressure you need, and in some people, actually, using CPAP is associated with problems. And so it's better to get help with a physician with expertise in sleep apnea to figure that out. Some people with COPD or other lung problems can't blow out against a positive pressure and actually can have even lower oxygen going on. Some people with severe heart disease actually on CPAP may not have adequate blood flow to allow the blood pressure to stay up from CPAP. So you may want to get some help with that. Now, there is a future model of care where everything will be done as an outpatient, where if you don't have significant heart or lung problems and don't have a lot of obesity, potentially doing a portable sleep study, finding out if you have obstructive sleep apnea, followed by something called auto CPAP, if you don't have any risk factors for having problems with CPAP, which is something to think about doing, but I wouldn't just start it on your own, not knowing what's going on. Another person, Mary Angela, had a sleep study and has been using CPAP for about 5 years. Is there any benefit to having another study? If you're doing well, then no. If you haven't had any major health changes, then no. But if you're having any problems, it's probably important to be reevaluated by the sleep physician, and at that time they can decide whether you need another sleep study. Lorraine asks, is there anything is too much sleep? Potentially, yes. Some people that are depressed may present with wanting to get more sleep. Some people have daytime sleepiness and may take more naps and things. And there are other sleep disorders other than sleep apnea. One of them is called narcolepsy, where people feel very sleepy no matter how much sleep they get. They may have other symptoms as well, and it interferes with their quality of life and ability to work. And if you do have too much sleepiness, there's a lot of causes of that. Like I said, there's more than 90 sleep disorders, which we didn't have time to discuss. But if you are having a lot of daytime sleepiness despite adequate sleep time, then I would recommend you be evaluated by a sleep professional. Insurance take care of a sleep study. It depends on the insurance. More common insurances used in our area, they do. They have different requirements about payment, and so I would check with your specific insurance company before to find out more information about your specific insurance. But yes, insurance does take care of almost all the expenses of the sleep study. So I think I've gone through most of the questions. I think I have 6 pages of questions here. So anyway, thank you very much
Yeah, thank you.
participating.
Thank you for attending. We're out of time for questions. We'll try to get some of these answered and posted online when we post the recording of the webinar. We'll work with Dr. Harding to get that done. But in the meantime, if you would like to speak with her about your specific circumstances, you can do that by scheduling a consultation. And you can see on your screen the URL to go to the appointment form to make an appointment with her, or you can call her clinic directly at 930-7714. So thank you for attending, and schedule a consultation if you feel like you should. Thank you.